All right, so thank you so much for having me. So the only disclaimer I have is I'm a neuro-oncologist and neurologist by training, not a neuroradiologist. So I have a certain bias when it comes to imaging. So I will start with just talking about the standardization efforts that we have ongoing in neuro-oncology. And I think these are the things that we don't talk enough about, so it's really important to highlight them. First key to this initiative is the publication of the brain tumor imaging protocol, or BTIP, in 2015 by Ben Ellingson and colleagues, which established desired parameters to be used and sequences to be used to image primary brain tumors. One of the key things, need to go back. So one of the key things I want to emphasize in this is the recommendation of thin slice images and 3D image acquisition, which is really, really key if we want to do machine learning applications in the future. This publication was followed up in 2020 with the BTIP brain metastases recommendations, which are largely similar to the primary brain tumor recommendations, but with a few tweaks that allow us to generate better contrast using TSC instead of GRE images for small brain metastases and allow us to detect calvarial lesions. But one of the key things I want to emphasize is this manuscript also increased recommendation for standard parameters for perfusion, which is becoming standard of care in neuro-oncology. So the next important initiative I want to talk about is the Brain Tumor Reporting and Data System, or BT-RADS. This is an initiative that is coming from Emory, and it essentially utilizes the FLAIR, the T1 gadolinium, and the treatment information to standardize the language of MRI reports in neuro-oncology and harmonize the interpretation across the board of providers and neuroradiologists. The score goes from 0 to 4, where 0 represents the baseline image, 4 represents unequivocal tumor progression, 2 represents no change. And the most debated area is score 3, which is subdivided into 3 groups of certainty. So 3A favors treatment effect, and 3C favors tumor progression, and 3B is indeterminate. So this is not perfect, but I think this is a very reasonable compromise to help synchronize the language we're using around interpreting imaging. So I'm going to talk a little bit about new and old imaging tools, and one of the more exciting ones is 2-hydroxyglutarate imaging using MR spectroscopy. This is not a representative set of images, unfortunately. So on the right, you can see a super resolution MR spectroscopy image, which is generated using upsampling of the conventional MR spectroscopy and combining it with some of the data from the structural imaging. So this is not really representative of the state of the art, and it's not really representative of how in reality the data is acquired. But I'm hoping that in the next 5 to 10 years, this will become standard and we will have such high resolution 3-dimensional MR spectroscopy images. The next newer kid on the block is chemical exchange saturation transfer, or CEST MRI. This is a method that utilizes radio frequency excitation to saturate the signal of exchangeable protons on molecules we want to quantify. And as these protons get exchanged with the surrounding water, we generate a negative contrast, and we can pick that up on imaging. And we can do multiple transformations to generate a magnetization transfer ratio, which can be mapped out and used to quantify drug concentration or compound concentrations in vitro, as well as in vivo. One of our interests at Hopkins and the push that we have is to develop novel contrast agents using CEST by transforming already available, safe, FDA-approved agents such as sugar This paper was published a couple of years ago showing glucose signal within a low-grade glioma after the administration of a bolus of glucose. And we are working on developing dextran to varying weight dextrans to map out the permeability of tumors. And the basic idea of this, and this is sort of a timeline or map of what it would be interesting to develop, going from the lowest molecular weight contrast agent glucose through gadolinium, through dextran 1, 10, and 70 to develop detailed permeability maps for tumors. And the next thing, next exciting thing in CEST imaging is potential use for PK imaging. So my collaborators, Drs. Liu and Van Zyl, have shown that certain anti-nucleotide and anti-folate chemotherapy drugs generate a CEST signal that can be actually captured on an MRI. And just a demonstration animal model that you can map out the distribution of these drugs. So I'm going to talk a little bit about radio tracers. One of the newer, increasingly used tracer is dotatate, which is a somatostatin analog. It's actually gallium-68 gallium dotatate, which is used in meningioma imaging. These grade 1 meningiomas express somatostatin receptor 2, which allows us to image them, and many of the grade 2s and some of the grade 3s as well. So it helps delineating targets. And I'm going to talk a lot about amino acid tracers. One of the new and coming ones is fluciclovine or Examin, that is already FDA approved for prostate cancer imaging, and it is being studied in the context of neuro-oncology. So I'll get back to this tracer a little later. And the last very exciting tracer to me is developed at Hopkins. This is a CSF1 PET tracer. It's highly specific to microglia, and it will allow us to better map out the neuroinflammation and the pre-metastatic and metastatic niche that is associated with brain cancer. So going back to the big questions in neuro-oncology, once we have the initial diagnosis, it boils down to really 2 or 3 questions. And the first one is, where are the margins? The second one is my treatment working? And if we see changes, is it treatment effect or is it tumor progression? But the third thing is actually the more exciting question. And I think in the next decade, that's where imaging will reposition itself, is developing predictive radiographic biomarkers to guide decision-making. So instead of committing to potentially toxic treatments that don't necessarily work, we could help choose the right drugs for patients using imaging. So I think you guys have already seen this figure, and I just want to emphasize again that gliomas are whole brain disease. So you see cancer cells even in the macroscopically and radiographically normal volumes. So because of that, local regional therapy is not going to be curative of these tumors, but still there are important improvements that could potentially be made. So just going to the regular classical approach, we have a drug that we inject into the patients, and we do a pharmacokinetic analysis, and that's actually the contrast, gadolinium contrast imaging. You can do it dynamically, and that's perfusion. So you have a general vague idea about the blood-brain barrier breakdown, but only at the level of gadolinium. And when you look at the T2 FLAIR image, which is highly sensitive but highly non-specific, you will see this. So this is a combination of scar tissue, pure vasogenic edema, and tumor-infiltrated edema, and there are no margins here. So along these lines, me and my collaborators, we did a study about a decade ago using an amino acid PET tracer called AMT, or alpha-methyl-tryptophan. I manually segmented the metabolically active tumor volume, the T2 FLAIR, and the gadolinium volume. And not surprisingly, what we found, and this is in gliomas, that the T1 gadolinium volume was the lowest, and the T2 FLAIR volume was the highest, and the metabolic volume was in between, and all of these were significantly different. In a subsequent concordance analysis, what we found is that 20% of the tumor volume that we see were exclusive to the amino acid PETs, and 40% of the T2 FLAIR hyperintensity did not have corresponding metabolic signal. If you look at the right side of the figures, you can see that all GBMs had amino acid PET exclusive area, whereas some lower grade gliomas had those too, not all of them. One caveat is that the gadolinium enhancing volume was also always metabolically active. We followed this up with an analysis of a couple of patients with surgical sampling of these areas based on the imaging findings. And not surprisingly, the solid tumor defined by gadolinium enhancement, which was again metabolically active as well, had the highest semi-quantitative tumor cell concentration. Areas that appear radiographically normal had still had tumor cells detectable, and the metabolically active but non-contrast enhancing tumor volume had an intermediate tumor cell concentration. And this takes us back to Dr. Orlov's excellent presentation about how should we think about margins. And one of the things I think would be the best approach is to think about tumor cell gradients. We cannot delineate the whole thing, but we could potentially establish a metabolically active tumor volume where we can make a difference. I actually removed that figure, but I've had a 5-ALA study referenced using FET-PET, which is another amino acid tracer, that showed just that this was a German study, or a French study. They couldn't get negative margins using 5-ALA, but there was always the residual PET and MRI positive areas were all positive for 5-ALA. So there appeared to be no false positives based on MRI or PET. So a follow-up study on this was in 2015 using FET, which stands for fluoroethyltyrosine, where they assessed the prognostic value of the biologically, the metabolic tumor volume. So high PET, I'm just going to refer to it metabolic tumor volume. So those patients who had low metabolic tumor volume had better survival than those who had high metabolic tumor volume. And the most important thing of the study is not that, but they divided the patients to a group who only had biopsy and another group who had resection. For the biopsy group, the initial metabolic tumor volume was prognostic. However, for the resection group, only the post-resection metabolic tumor volume was prognostic. So it's not predictive, it's prognostic. But it gives us an idea that this is not an inherent characteristic of the tumor. We might be able to surgically modulate this and do more adequate cytoreductions using PET targeting. And of course, the study involved a multivariable analysis where the PET volume actually completely obliterated the MRI volume as a predictor of survival. So another study, which was published a year ago, followed this up using an identical tracer, essentially MET, which is C11-methionine. They recruited newly diagnosed post-operative patients who got a PET scan before radiation. They established the metabolically active tumor areas, as you can see here, and they included it in the radiation field. And then they assessed the patterns of recurrence and survival and outcomes. So one of the main findings was that 45% of the patients who got gross total resection defined by MRI still had residual metabolically active volumes, and only 33 patients who had, only 33% of the patients, so 1/3 of them had no residual metabolically active tumor. So this is quite shocking, and I think it may explains some of the inconsistencies in the extent of resection studies. And it also emphasizes that it may not be the actual extent of resection, but the residual tumor volume that mattered. So this study also included a multivariable analysis for overall survival. Here, the MRI residual survived the adjustment for other factors, but metabolically positive volume remains highly prognostic for survival. And if you can see, if you look at the Kaplan-Meier curve here, the metabolically negative and MRI negative volumes, patients with MRI and PET negative resection margins lived significantly longer, and those who had metabolic activity in the residual areas had a shorter survival. But the kicker is here. 80% of the recurrences still happened within the radiation field local to the area of MET positivity. So I think PET can help guide surgical resections and planning, but the regular radiation techniques may not make a major difference when it comes to integrating amino acid PET. And the follow-up of this study was a plan to do a boost study where they boost a metabolically active volume. And a similar study was performed in the United States, led by Emory in collaboration with University of Miami and Johns Hopkins, where they used MR spectroscopy and they used a colon to NA ratio maps to deliver a 75 gray boost. So 15 gray boost to patients. This was a phase 1 study. It completed and enrolled 30 patients and was deemed safe. The anecdotal part of it is I've had 3 patients of the study and they all outlived the expectations by a year. But how do we approach response assessment these days? So this is a time-lapse view of a patient who was an IDH mutant tumor and was treated with off-label ivosidenib at one point. And as you can perhaps appreciate, the tumor expansion slowly decreased to some extent on ivosidenib. We did one-dimensional, two-dimensional, and volumetric analyses, and I think you can appreciate the volumetric changes were the most remarkable. So that puts a question as to what are we missing by just looking at the 2 largest perpendicular diameters to assess response by standard. So this is the same patient from a sagittal view, and you can see we are missing a lot of information on the time lapse if we just are focusing on a single cut. So this was also corroborated by Ben Ellingson's recent paper in neuro-oncology, comparing the standard Raynaud low-grade glioma biperpendicular diameter versus volumetric analysis, and they showed that treatment response assessment was much better using volumetric data. So the problem with volumetrics really is it's difficult to do it. I think computational advancements were necessary for us to be able to do this more consistently. Another trial that I want to show is the Severum trial, which used everolimus and octreotide to treat aggressive recurrent meningiomas. And they had shown a significant change in the growth rate of these meningiomas on the volumetric analysis. So before treatment, it was about 17%. Growth actually halted in the first 3 months of treatment, and then it remained reduced for the second 3 months of treatment. So this was a fine demonstration as to how to still capture activity of regimens that may not lead to partial or complete responses. So going back to the segmentation issue, the last important initiative I want to talk about is the BT-RADS, or Brain Tumor Segmentation Challenge, that collects AI experts from all over the world to train AI to do the segmentations for us. And it's becoming really, really good. So I think in a couple of years, we won't ever have to manually segment tumors. We will just rely on these algorithms. So the last couple of things I want to talk about is, again, Examin, an amino acid PET tracer that is approved by the FDA for prostate cancer imaging. And preliminary data showed that it was also helpful in differentiating malignant lesions from necrosis in previously radiated patients. And there are two concurrent prospective trials going on. One is the Perfusion trial, which is phase 2 and tries to assess the best way to interpret full cyclovine images. And the Weighte study that is a phase 3 to assess the utility, sensitivity, specificity of Weighte to distinguish radiation necrosis and recurrent tumor. We are assigned for this study, and I just enrolled the third patient, so I'm very excited about this. And the last thing I want to talk about is distinguishing tumor versus necrosis using Amide proton transfer, or APT, which is a form of CEST imaging done at Hopkins, and this is just a validation study of 60 biopsy specimens from 20 patients, showing that low APT signal predicted necrosis, intermediate signal was associated with necrosis combined with scattered GBM, and the high signal was actually predictive of highly cellular and proliferating glioblastoma. So a lot to cover, a lot of excitements. I just want to thank all my collaborators within the oncology group and at KKI, and outside of Hopkins, Drs. Juhas and Mehta. So thank you very much, and thank you, Dr. Smith-Cohen, for having me.